Good afternoon, everyone. Thank you all for joining online and in person. I would like to welcome you to Project Echo, a program by Dr. Santos and Dr. George. This initiative hosts monthly sessions with specialists from our Health Science Center to educate primary care providers in rural and underserved areas of West Texas. The goal is to address key metabolic and health disparities through case-based scenarios with hopes of reducing unnecessary referrals, labs, and procedures, and ultimately drive down healthcare costs to our patients. You may occasionally receive emails from our Project Echo team inviting you to host a presentation or participate in a panel specialist in the future. Keep an eye out for exciting details. Before we begin, a few quick reminders. If you're attending online, please stay muted throughout the presentation. CME credits are available for this event, but if you must complete an evaluation survey at the end of the presentation. We will have a reminder again at 12:55. For those attending in person, please ensure you've signed in at the paper at the front. This educational activity is supported by TexLab Resource Center, a federally funded program by F. Murray Hall, Rural and Community Health. So now today's presentation will be given by Dr. Sneed, the Program Director for Masters of Science in Addiction Counseling Program, Associate Professor and Clinical Assistant Professor for the Department of Psychiatry.
Hello, my name is James Nichols, and I'm a second-year medical student. And so what I'm going to be doing is I'm going to be introducing to you a case study about an individual struggling with substance abuse and mental health disorders, followed by Dr. Sneed, who's going to be giving a didactic lecture about how we can use telehealth to increase access to healthcare in treatment of addiction and mental health disorders. So to introduce the case, 46-year-old male presenting via telehealth reports that he's been drinking more lately, he's not sure how to get help, and it's really hard to make it into an appointment. And just a few pointers that has increased alcohol use, he lives in a rural community, he has very limited transportation, he has not had formal treatment before, and he's reporting poor sleep, anxiety, and low mood. So going over the HPI now, Mr. R is a 46-year-old male presenting via telehealth for evaluation of increased alcohol use. He's reporting that his drinking has been increasing recently over the past year due to ongoing stressors because of job loss. He's regularly consuming about 6 to 8 beers a day. He has occasional binge episodes on the weekends, and he's previously tried to cut back on drinking, but he's not been successful. He lives in a very rural community. He's more than 100 miles away from any near addiction treatment facility. His transportation is limited. He can't travel to appointments. He's never received any formal treatment, but he has attended a few, online addiction anonymous meetings. And his main concern is that he's having difficulty sleeping, low mood, anxiety symptoms, but denies any suicidal ideation. His main interest that he wants to get out is that he wants to see what options are out there that don't require him to travel so much. So this review goes into our review of systems. Generally, he reports having poor sleep, fatigue, and no weight loss or any fever. He appears slightly disheveled through the telehealth, but he's sitting comfortably in his living room cooperative. He, again, as part of the HBI, he has low mood, anxiety, but denies any hallucinations, delusions, or suicide ideations. He reports occasional nausea after drinking heavily, but no major GI distress or upsets. The physical exam was limited due to the nature of it being telehealth. However, he appears alert and oriented. His speech is clear. He has a tired mood, and his affect is a bit constricted. Otherwise, he appears normal, and no other physical anomalies were noted. Now I'm going to introduce Dr. Sneed, who's going to present the rest of the didactic lecture. He has a PhD in rehabilitation from Southern Illinois University. He's the program director for addiction counseling. He is a clinical assistant professor, co-editor-in-chief with Alcoholism Treatment Quarterly. He's a distinguished fellow in psychology and national academics practice. He's a professional SME for SAMHSA and the NBCC, and his research interests target both co-occurring disorders and coexisting comorbidity disabilities. So now I'll give the floor to Dr. Sneed.
Thank you. Greetings, everyone. I'm kind of nervous about this microphone. Sometimes when I get to a mic, my voice kind of beats it up a little bit. So this is a really interesting case. Here we go. So I started with just sort of a primary working diagnosis, and I've listed, and I think most of you, right, would go, oh, it seems like possibly alcohol use disorder. Does that seem about right? Yeah. So right now we don't have a whole lot of information. So I might start with rating the severity of it around the mild, but it's daily use. So should I be concerned about daily use? Typically, yes. Whenever it comes to alcohol use, anytime a person reports they're using it daily, we go, oh, okay, wait a minute. This is a warning sign, something that could be important for me to pay attention to. There are some things that he's reported that link or make me think about psychosocial impairments. He's recently lost his job. He's reporting anxiety. That could be the word that he's using. It could be something else, but also difficulty sleeping. Now, anytime we're looking at a case like this, we have to think about a differential diagnosis. And some of the other things that come to mind for me, well, first and foremost, I thought major depressive disorder. That could be certainly a possibility. Fatigue, low mood impacts the sleep, right? Now, the important thing here is to identify whether or not it's substance induced, or in this case, specific case, if it's alcohol induced versus a primary mood disorder, because they would have different treatment approaches. But telepsychiatry could be really helpful. If we thought this was the right thing, that we needed to go after this diagnosis, we might want to consider a referral to someone else, or at least a consultation. Generalized anxiety disorder is also frequently very common. Reports anxiety. Now, again, whenever I hear people say anxiety, I have a lot of questions about why they're choosing that word, and I want to understand better what they mean. Like, how's that happen for them? Then we have alcohol-induced mood or anxiety disorder. So again, with all of the insert a substance followed by induced disorder, what we see is that the actual use of that substance is what's causing the manifestation of the symptoms. And so it can be really different from alcohol use disorder in and of itself. And then the last thing I wanted to highlight, and we'll talk a little bit more about this, is alcohol withdrawal syndrome. And so this is a risk that we're looking at, because we know that alcohol is addictive. One of the things that we see frequently when people try to suddenly stop using alcohol is that they can experience a withdrawal syndrome. There are times when it can become severe and even life-threatening. Now, the chance of this and the severity of this goes up with how long a person has been drinking alcohol, as well as their volume of intake. This person reports 6 to 8 beers a day. Does that feel like a lot? Yeah, I'm seeing some yeses, and the people in Zoom, I'm positive, are agreeing along with us. It is a lot. So typically, the recommended level of alcohol intake in terms of nutritional guidelines for Americans, at least for males, is less than 14 per week. But it's also recommended to be fewer than 4 per day. At the same time, does anyone know what the most recent estimate from the Center for Disease Control, National Institutes of Health, on how much alcohol is safe for a person to, how much can you consume before it's harmful to your body? This is a weird trivia question. I saw a 0. It's close. It's really, really close. 0.1 ounces. So at 0.1 ounce, the dose starts to harm the body. And so if you think he's drinking 6 to 8 beers, these are probably 12 ounces to 14 ounces, maybe more. We don't quite know. So he's above the level of experiencing harm. So what do y'all think? I want to ask the audience some questions. What barriers to care are evident with this case? And what immediate concerns would you want to address in this encounter? Anybody?
Access to care.
So from the audience, we had access to care, right? This person is telling you right away, I don't have access. I don't know where to go. It's too far. I even have transportation problems. And so that's one of the great things that telehealth and telemedicine can do, is it can extend the care and bridge some of those geographic divides. It's interesting. And that leads us right to that third point. So what limitations or risks do we need to keep in mind when we are trying to treat a substance use disorder through telemedicine? What do y'all think?
Going through withdrawal symptoms.
Okay.
To mitigate withdrawal symptoms, trying to take someone off of those substances.
Okay, so the answer is going through, trying to mitigate risks whenever a person starts going through withdrawal symptoms, and that's absolutely correct. We like to think about patient safety. We have to take care of them. So, and what we know about several of the substances is that they can produce not only aversive withdrawal syndromes, but also potentially dangerous withdrawal syndromes. So, good responses. So let's talk about just prevalence of alcohol use disorder. And this is one of the more common types of conditions that occurs among Americans, and we often don't really think of it that way. But I've pulled some very, very recent data, and I have all these on the reference page. So if you want a copy of the handout and look at the references, you can access it. But during the prior year, 27.1 million adults, American adults, that's age 18 or older, had a past year alcohol use disorder. And that's according to the National Institute on Alcohol Abuse and Alcoholism, or NIAAA. And they acquired this information through the National Survey on Drug Use and Health, which is an annual survey they do every year. And it's considered the gold standard of understanding how Americans are using substances and what's going on in their life. So whenever we think about that, we go, well, 10%, 10.3%. To someone like me, I study alcohol use and substance use. I pay a lot of attention to it. It's a really prominent feature of my career. Does 10% sound like a high number? I'm seeing a couple people saying no, a couple saying yeah. You know, so if we think about that, right, like 1 out of every 10 of our patients that we see could potentially be presenting with this. But I said earlier, you know, I study this, I spend a lot of time with this. I think this number is underreported. I think the number is probably closer to 20%. And we often see that in survey data, is that there's some sort of social desirability bias in the way that people respond to things. Now, that doesn't mean that in any given year, 27 million adults actually actively seek out and get treatment. In fact, 1 out of 10 people that want treatment gets it. 9 out of 10 people that ask for treatment or want to go to treatment do not or are not able to access it. So this is, again, an access to care issue. Many Americans right now are really focused on living a healthier life, doing things that get a little bit better. Interestingly, I didn't include the data here, but right now, especially among young adults, there's this attitudinal shift towards alcohol use where people readily go, that's not good for me. That's not good for my health. And so more than ever before, the youngest generations are saying, "No, I don't have space in my life for that." Or the ones that are using it are going, I want some help with this. They're often turning to their primary care providers, their family physicians, other sources of help. Because if we go back 10 or 15 or 20 years, that wasn't always accessible. Accessing substance use care has changed a lot within the last just even few years. And I always like to point out, just as another random trivia component, when the Affordable Care Act passed, that was the first time that we had widespread insurance or access to care through insurance panels. And so that's just 11 years ago. And so many Americans are sort of going, hey, you know what? This is a thing that I expect now. It's easier than ever to access. So that's exciting. So let's talk about indications and advantages for telehealth. What it can do for you in terms of telemedicine or telehealth whenever you're working with addiction and psychiatry issues. First off is it gives you the opportunity to conduct an initial assessment, which can be a real time saver. So if in-person access is limited, this is one of the ways to jumpstart treatment, get someone involved, also get some information, and that will help you identify other types of resources or tests or labs that you might want to order. If ideally plans for an in-person evaluation is needed. It also allows us to conduct routine follow-ups for stable patients on what's called medication-assisted treatment. You'll see this in the literature. This is often referred to as MAT. And so MAT protocols, MAT methods, and the MATE Act from 2022 really focuses on this. And so do y'all recall the MATE Act? How many of you are familiar with it? I'm seeing just a couple hands. So the MATE Act sort of, let's just say, abolished a prior restriction that existed in terms of MAT protocols. So buprenorphine is an opioid indicated medication. It helps people jumpstart treatment. It helps them stay in treatment. It blocks urges and cravings related to opioids. And so if the person tries to take something, you know, which we know is common whenever we think about return to use, but say 5 years ago, you had to have what was called an X waiver to be able to prescribe buprenorphine. And so the hoops that a physician had to go through to, and I say hoops, I shouldn't be so disrespectful, but many people were sort of frustrated by having to go through some extensive training to be able to get a waiver to be able to prescribe it. So in 2022, the May Act was passed and it changed those guidelines and it moved buprenorphine kind of into the hands of everybody. Because what we want, and we know from the opioid epidemic, we want people being able to access treatment lots of ways. That could be accessed through their family physician, their primary care physician. So, not everyone has to go to an ultra high-end luxury, 32-day residential facility program. There just aren't enough of those. So moving to the third bullet, I can get kind of on a high horse about some of these things. So I want to keep moving. Medication management for psychiatric conditions or substance use with remote monitoring support. So again, another extension of telehealth and telemedicine is that it allows you to stay in touch with your patients. They won't have to travel as frequently, and you can monitor medications. The piece that I love, and I train all of my counseling students in this, and I work with medical students in this area as well, is behavioral therapies and counseling. So now more than ever, people have figured out, and I say this kind of silly, but during the pandemic, everyone went home, right? Everyone was isolated. And a lot of people came to this realization that they had feelings and that it was okay to want to talk to someone else about it. So what that's caused, along with those Affordable Care Act changes, is just a literal boom in the number of behavioral health and mental health providers that provide services virtually. Has anyone seen a commercial or heard a commercial for one of these recently? They're just all over the place right now, aren't they? And the other day they were coming on and I heard one on my radio station playing, and I was like, I had this thought to myself. I was like, I wonder if they think that I need to hear this, or if they're just average. Like, is this because you know how Google listens to you and Apple listens to what you're looking at on the internet? And I was like, well, it's probably just everyone's interested in it right now. The bottom piece and our case reported, our individual from the case reported trying to access some of these and to not much effect. But online therapy groups or online support meetings. Now, I want to call out sort of a difference here. Whenever we say group therapy, or if you're going to use the word group therapy, it's really important that you're talking about an organized group that's led by a professional. There's someone there that's in charge. They have a license to do something. And that could be a social worker, a counselor, a psychologist, a marriage and family therapist. It could be someone like that. Whenever we say an online support meeting or peer support or self-help, what we're talking about is typically something like you might recognize AA or Alcoholics Anonymous or Narcotics Anonymous. Now, the reason I want to point this out is that the American Society of Addiction Medicine, or ASAM is the acronym they go by, does not recognize peer self-help as any level of formal treatment. And so as providers, as future providers and current providers, we always have to be mindful of that. If we're going to do something for our patients and try to help them, we can recommend a support meeting, but that shouldn't be the only thing that we recommend. That shouldn't be where our treatment plan stops, because it's not considered officially treatment. Now, the reason, and I'm a big fan of AA and things like that, but it's not right for everyone. And so I always caution folks before you just start sending people to an AA meeting, do some learning about what it is and about what people are asked to do when they join those meetings, because it'll really help you identify whether or not this is the thing that you want to affiliate with through your practice. They do some interesting work. But again, it's not right for everyone and not right for every type of issue. Now, benefits of telehealth and telemedicine, obviously access. Also continuity. We have the ability to generally to see our patients on a more regular schedule through telemedicine or telehealth. And I say this fully knowing, so I help lead some clinical services here, and I have patients and families that live hundreds of miles out from where I am. And so what we do is we use telemedicine and telehealth to bring that provider interaction to them where they are. It saves them time, it saves them money. Kids don't have to leave school, adults don't have to leave work. You know, if we think about them traveling, taking off a day of work and then traveling and then back and forth, that might impact their ability to buy other things in their life. In terms of the evidence base, and I won't belabor everything here. I've put 3 bullets that I just really, really like. It's effective for mental health and addiction treatment. So it's really interesting. In the beginning of telehealth, people said, "Oh, I don't know about this." Anybody, do you know when telemedicine started? Who knows how old it is? I see Dr. Santos. Do you know? This is a deep trivia question here. The 1950s, and Dr. Santos for the win. You're completely correct. 1950s. So we are 2025, right? We're about 70 plus years into using telepractices and having an evidence base behind it. So we know now that it works for mental health counseling. We know that it works for addiction. We know that it works for psychiatry. There's always a piece where people are sort of providers and professionals hold back and they go, no, there's something that's so special. They won't say this, but what they're feeling is there's something so special about me and being in the same physical space as me that it must not work. And I always challenge folks that no, our practices work, the methods work, there's a science to it. It's not always easy, but we know that it is effective. Now, it doesn't work for everything, doesn't work for everyone, not every type of mental health disorder. And I'll get into what a few of those are in just a moment. Improved retention. So we know that one of the things we see in addiction and psychiatric care is issues around retention. Does the patient come back? Do they follow up on their treatment? Are they adherent to what you want them to do or what you recommend? With telehealth and telemedicine, this gives you a way to check in more frequently or for them to check in more frequently. And what the research has found is that people tend to stay in treatment longer and better. Back to what I said earlier is it gives you an opportunity to monitor treatment, make quicker fluctuations or quicker changes as you go. That means that treatment gets better and that people's health improves more quickly as well as patient safety goes up. And then telehealth removes barriers. We don't need to talk about all that because we've been kind of focused on it. Now, like any good researcher, right? We say more research is needed, right? Well, I'll never say anything but more research is needed. We still want to know more. We want this to continue advancing. But right now it looks really promising. Now, cautions for telehealth, telemedicine, whenever it comes to addiction and psychiatry. There are some people in communities that do not have broadband access. Now, that's often the first thing we think of whenever we think of telemedicine, right? Is like, I'm going to be in a Zoom or a Google Teams or something, some other sort of video software, video back and forth. And that is preferred. But there are instances where audio only formats can be okay. And I mentioned the May Act of 2022 for what we're talking about today. That is actually approved. Audio only with the patient at the distant site can be one of the methods that the physician connects with the patient through. Now, at the same time, when people live in communities where they don't have good broadband access, there are some of our communities out across very rural regions where people don't have good access at all. And so there it becomes sort of a juggling act and trying to figure out how to increase access in those regions. And I always encourage folks to, professionals to reach into the university and our telehealth resources to see if there's any ideas, any solutions that already exist. Sometimes telemedicine might not be covered or certain types of visits might not be covered by a person's insurance plan, or there could be limitations to their plan on sort of the order or the sequence. Like, so maybe it does have to originate with an in-person visit first, or maybe there has to be an in-person visit within a certain number of days of that first telehealth visit, telemed visit. And then at the same time, types of providers. So there could be limitations on, how many things can be billed or listed in terms of telemedicine, in terms of, I'm thinking of, say, like counseling or therapists, whether or not they can be involved at the same time. Now, so there are certain conditions and I would say conditions and kind of lean away from diagnoses and just really focus on things that a patient might exhibit or things that you might hear that they're exhibiting that would typically require an in-person visit. And then, so telehealth would not be a recommended medium. The reason for that is patient safety, physician accuracy, provider accuracy, but severe mental illnesses are not typically indicated for telemedicine and telehealth visits until the person is stabilized and doing reasonably well. So, but if someone presents and they're saying, oh, these types of things are going on, I'm seeing things that aren't there, or my wife says I'm seeing things that aren't there, That's a good indication that maybe telemedicine is not the most appropriate route yet. Doesn't mean that it can't be. We also have some contraindications around psychosis. Anytime there's risk of self-harm, a significant risk of self-harm, or acute withdrawal from specific substances. So these are things that we have to plan for. Other times might be where we need to be able to observe the person, or we want to make environmental observations. So think about things like eating disorders, being able to see how the person relates to food, things like that, even family dynamics. And then probably the most frequent one is this last bullet, and it's challenges related to logistics. How many of y'all have had a telemedicine or telehealth visit with a person on a cell phone, right? A few people. What I always experience, at least once a month, maybe once a week, depending on who I'm working with, is the cell phone starts doing this, and the person is talking and they get really animated. And what am I seeing? Everything but the person. So sometimes I have to talk to people about sort of behavior, manners. I work sometimes with adolescents. They're talking and then they just throw it down because they're frustrated or something. And now I'm staring up their nose, or I'm staring at the ceiling and I can't tell what's going on. At the same time, I've had many instances where people would say, they're talking to me and their spouse overhears them from the other room. And what does their spouse do? They correct them. They said, no, that's not what I said, or that's not what happened. You need to tell the truth. And so we have issues around privacy, and whether or not that patient feels like they can be honest and share. It's really, really interesting. I'll share briefly one of my, I think, more fun instances for me in telehealth. I was trying to work with a patient who was in my waiting room, and I admitted him. And then I saw he was walking around, and I was trying to get his attention. He had me on his cell phone, which I don't love, but I could see his face, and he was waving it around. And at some point, about a minute or two in, I realized he's at the liquor store and he's buying alcohol during his visit for alcohol counseling, for counseling related to alcohol use. So I was able to call him out. I caught his attention. He almost dropped his phone, and then he's like, no, I'm not at the liquor store. And I was like, well, that's a wall of liquor right there. Like, I can see everything you're looking at. So it was fun for me. I don't know that it was fun for him, but it was a good opportunity because I could check out his environment and see what he was actually doing. But because he was in a non-private place, we had to suspend the visit, and I had to get him to go to another facility, another location where it was private. And that's frequently a thing that patients will do, is they'll go to some place in their community where there is good broadband access, and they'll try to have a medical visit there. And that's not appropriate for us. So we try to teach them along the way and coax them into going somewhere better. Now, some applications and special considerations for addiction and psychiatry. I've talked about virtual counseling and group therapy. Typically, most patients will prefer an individual counselor at first. But what I'll say is that more people benefit from a group counseling approach. And the reason for that is that usually when a patient is with the one-on-one provider, they want to talk about their problems and how unique everything is. And that's fine. There's nothing wrong with that. But one of the faster ways to provide treatment is through a group therapeutic approach, because often people who are struggling with addiction and psychiatric issues, they think that they're the only one that's experiencing this kind of symptom or this thing that's going on in their life. And when they hear 4 or 5 other people have the exact same thing, it's a really synergistic effect. It helps them go, oh, I'm not alone. I'm not the only one. There are other people that have experienced this. There are other people making success. So it gives them a chance to try some things. I've talked about MAT prescribing a little bit already, and some digital monitoring tools and apps. Now, I put crisis intervention here because some special considerations go into this. With crisis intervention, anytime we're providing telehealth, telemedicine, we need to have a crisis intervention plan technically on file. This should be some of our paperwork that we have, that we filled out and worked through. The patient understands it. If we have a distant site provider that's linked with us, they're included as well. If you don't have that distant site provider, it's just a patient and you connecting, then the paperwork and the plan resides with you. The patient has a copy, but you need to know who to call, who to reach out to, how to get a hold of someone in that patient's community should a crisis develop. So I describe it as a local contacts. In some instances, that might be the sheriff's office, depending on how rural the person is, because there might not be other people nearby, but it should include family members and neighbors, other folks that the patient agrees can be involved in the event of an emergency or a crisis. It doesn't mean that they have access to the patient's materials and the rest of the plan. Now, I mentioned this other one on the far right side, technology literacy. This is another one, internet access, but technology literacy. I saw in the beginning, we have a slide and it says, hey, look up here at the top of your screen and click the view button and you can, and I was like, hey, great. In my experience, almost nobody that uses Zoom understands how to change their screen settings. So you could look at me, you could look at yourself, you could never see yourself. That's the thing is that with telemedicine and telehealth, as the provider, either we need to be prepared to do it or we need someone on our team that can walk the patient and their family through that technology, either setup, use, or troubleshooting. And so this can get a little bit tricky. How many of you consider yourself high-tech users? You're ready to walk people through all kinds of IT issues. There's like 1, 2, 3 of you. Oh, I see a 4. And none of you raised your hand proudly and waved it around. It was all like, please don't call on me, or I'm confident enough that I could do it. Most of us aren't in school for as long as we went to school to learn those kinds of skills, right? And so it's important to me that I have people on my team that can do those things for me, because that's not what my patients are coming to see me for either, but it's a responsibility I have as the healthcare provider. Now, I mentioned privacy, confidentiality. When you are providing services related to addiction and psychiatry, there are typically slightly higher privacy and confidentiality considerations that go into it. This is tricky because I'm trying to read the tea leaves on what the feds or the federal authorities are going to do. But within the last year, they did significantly modify confidentiality requirements around substance use care. And so this is ultra deep trivia. You have to be a trivia wonk to know this. Has anyone ever heard of US 42 CFR Part 2? No. Okay, just me. So I'm the policy wonk. That was a federal code, so Uniform Code of Federal Regulations 42. Let's just say 5 years ago. It prevented me from being able to put a note into an EMR about substance use care unless I had, say, like 6 or 7 types of forms filled out, and my clinical practice was classified as an addiction facility. So that, for years, led many physicians and large practices to say, we don't want to do that. We don't want to be that kind of thing that changes the way that we operate financially. It changes the way we keep records. So that's why oftentimes in the past, many people were referred to specialty providers. So this shift within the last year took that ultra kind of by itself confidentiality regulation and really put it in line with HIPAA guidelines. And so now the goal is that people can get care where they are able to access care, and that no one has extraordinarily high security and confidentiality burdens that keep people or keep patients out of care. So it's a net benefit. It's a net positive. And I'm kind of expecting within the next year or two that those regulations to ease up even a little bit more. So I want to return to our case. I'm trying to be mindful of time. And so I've got, I think, 2 or 3 slides related to this. So this is evidence-based treatment protocol. So, we had the case, Jimmy gave us the case, and I said, oh, alcohol use disorder mild, could be these other things. Let's talk about some telehealth stuff. Really, the first step that we should do is a comprehensive assessment. And so on the slide, I've put a couple things, a couple acronyms that you might recognize. Has anyone heard of the audit before? I saw a couple of yeses. The Alcohol Use Disorders Identification Test. This is a public domain, evidence-based rapid screening tool for alcohol use. If you go online and you look it up, you'll find out that one, that it was funded by the World Health Organization. It's considered evidence-based by both SAMHSA and IAAA, Center for Disease Control. If you push even further, you can find online versions of it where you can ask the question, hit the button to get a score live while you're with the patient, and then it'll give you what the score means, next steps that are recommended based on your type of license and your type of practice. And there are even a few of those tools that allow you to copy, export, and paste into the EMR. So it can be rapidly fast. DSM-5 criteria, a little bit trickier to use, but typically with DSM-5 criteria, what we're looking at first and foremost is tolerance and then withdrawal, right? So whenever we hear that a patient can drink 6 to 8 beers a day, we go, that's probably tolerance, right? And he's reporting that it's going up. So if he was reporting that it was going down, we would say, hey, that's good, keep going that way. The tricky thing is that we don't want him to engage in a rapid withdrawal because we don't know if he's going to experience withdrawal symptoms. And so that can present cardiac issues, blood pressure issues, even chance of seizures and some other things. So it can be a little bit scary. On the other side of the criteria, we're thinking things about work, family, meeting role obligations that the person has, spending more time on it than they expected to. So loss of control issues. And he reported a few of these things. So I always remind folks, look at the DSM-5, the criteria, and don't use it as a desk reference. That's how I use it. I don't commit any of it to memory because I know how to use the book really fast and really well. But there's so much in it that like you can just sort of geek out and go, oh, I want to study more about this, or I want to read more. Now, the CWA, or the Clinical Institute for Withdrawal Assessment for alcohol, is a rapid tool that helps you assess for withdrawal risk for people who are using alcohol. So I recommend any of these tools. Here at the university, we all have access to the DSM-5. It's free, it's online even. But we should also screen for co-occurring psychiatric conditions and polysubstance use. Now, in this case, polysubstance use wasn't present, but typically what we find is that there is some level of other use. It's really common. If a person uses one substance, their chances of using a second one goes up. If they use that second one, their chances of using a third one goes up. So oftentimes what you find is that people will have some sort of combination of things that's going on in their life. In terms of medical history, an area you have to pay attention to for the assessment is that history, but any prior withdrawal complications. And I would ask this patient, I would say, hey, have you ever just stopped? What happened when you just stopped? What's it like if you don't drink? And try to get this person to tell me what's it like. Oh, I don't drink on Sunday mornings when I go to church. Well, okay, what's that like? What's church like totally sober? Sometimes people would say, oh, I'm hot or I'm sweaty. And if I feel like, oh, they're talking about, if they say shakes or I feel nervous or agitated, I'll go, okay, wait, the withdrawal risk is a little bit higher. Anyone that's had any prior liver disease, also especially with alcohol, is something that we should pay attention to. And then safety check. Always assess for suicide risk, home safety, and social support. That last one can feel kind of weird, social support. How many of y'all would assume everyone in the family thinks it's a good idea to stop drinking? Yeah, right. Like, this sounds good. You're going to get your health better. It's almost never universally accepted. So typically families exist kind of in a state of balance. And so whenever a person is a substance user of any sort, the family knows that, they expect that, they understand how to relate to the behavior. When a person goes through withdrawal and then early sobriety, even engagement and treatment, things are going to change and it pushes the family out of balance. And so people may like it or may not like it. At the same time, there could be other people in the family that say, use alcohol and have no intention of quitting. Or a person wants to quit smoking, but their boyfriend, girlfriend, partner does not. So it can create additional sources and layers of stress. So it's stuff that you want to pay attention to, so that way maybe it can get worked into the plan. I always recommend, whenever we're talking about alcohol, liver function tests, CBCs and CMPs. The reason for that is that these are basic patient safety issues around alcohol use disorder and around alcohol withdrawal, preparing for it. So if you have the ability to order labs at a local clinic somewhere nearby, that's definitely recommended. In terms of, it just flipped, okay. The risk stratification. So this is a piece of the assessment. If you would diagnose them as alcohol use disorder, mild to moderate, outpatient telehealth is probably appropriate for them. You can probably make that work. If they're at high risk of withdrawal, or if you're gonna diagnose them with alcohol use disorder severe, which means that they meet 6 or 7 of those DSM-5 criteria, then what we would probably need to do is refer them to inpatient care or an intensive outpatient, something that brings them closer to you, closer to more complex medical care. People who've had a prior severe withdrawal, unstable vitals, poor support environments, or severe comorbidity. So there's lots of other things that are clearly going on. That's a high-risk withdrawal scenario. We want to bring that person closer, if at all possible. So now, initiating pharmacotherapy, like I said in the beginning, or Jimmy did, I'm a counselor, so I'm not a prescriber, but what the teams that I've worked on have typically used as first-line agents, and what the research tells us is that naltrexone is especially effective for treating alcohol use disorder in outpatient settings. Now, one of the interesting things, and if you were going to prescribe it through telemedicine, you would prescribe the oral naltrexone. The reason for it is the other version is the intramuscular injection. And that's an office visit. They need to come in. The intramuscular is good for about 30 days. So it's often recommended to be used after the person has established some level of safety. They're making some stability in their early progress. And so at that in-person visit, that's when you would shift to the intramuscular dose. Acamprosate is another medication that's been recommended for use with alcohol, but it's not typically prescribed or used to start treatment. It's typically prescribed after the person has established, let's just say, sobriety. So they've quit drinking, they're working on maintenance, and acamprosate can help them feel better as they go. It promotes their recovery process. The stuff in the bottom, the second line agents, disulfiram, often this is also referred to as antabuse. This is not generally recommended for most settings. Even if it is, it's very uncommon in telehealth. The reason for this is that this is an antagonist. It produces severe headache and nausea. So when the person uses alcohol, they get this punishing effect from it. It is appropriate to use for people that are highly motivated. They're in highly structured environments where access to alcohol is limited or controlled, and doesn't have to be completely eliminated. But this is a medication that they have to take daily, and most patients report that they don't like taking it. And that's usually because they've tried to drink while they were on it, and they got really, really sick. So my next category, behavioral interventions. This is the piece. If you're going to do MAT, if you're going to provide services for addiction and psychiatry online, which I think is fantastic, you can level it up and increase people's chance of success by linking behavioral interventions with it at the same time. That's what the research tells us, is that medications work, behavioral interventions work. When you put them together, the success rate is much, much higher. And now more than ever before, behavioral stuff online is widely available. So I know some of you have heard about motivational interviewing before. This is a style of talking to patients that you can use, but other healthcare providers can use. It increases people's motivation. Like, it's right there. It's it's in the name. But also referrals to telepractices that focus on IOP or intensive outpatient programs, group therapy, or virtual mutual aid programs like AA or Smart Recovery. Now, those virtual mutual aid programs, those shouldn't be, like I said earlier, the only thing that you recommend a person do. AA, many people have heard of that. I don't even know the number of groups across the world anymore, but I know I've been able to look online and find all sorts of online groups, and I can help someone based on whichever characteristics in their life matter. So if they have an identity characteristic that they go, oh, I only want to be with people like me that have this guideline, we can find that type of support group for them. It's wildly available. Now, smart recovery is similar to AA, but more cognitively focused, and there's less spirituality involved. And that's often what people say they don't like about Alcoholics Anonymous or Narcotics Anonymous, is that there's a spiritual component to it. So if you have patients that say that, consider using or consider talking about smart recovery. And then monitoring and follow up. And we've talked about this, but typically we want to follow up with this patient 1 week after the initial check-in, and then weekly for early stabilization. With all things addiction and mental health, we have what's called a return to use. We used to use the phrase relapse. That's kind of fallen out of fashion now, because relapse triggers some strong feelings for most of us. We're like, oh, you're not trying hard enough. But addiction is a brain-based disease. And so a return to use or a return of the illness is normal for most other health conditions, right? So stabilization is what we're targeting. Now, you can do this a couple different ways. There are some tools. I wanted to put this last piece on here because I just wholeheartedly believe in care coordination. I don't provide any type of service alone. I don't think any of us can. Addiction is not any type of provider's individual problem. It belongs to all of us. And so if we work together, care coordination and referral, putting primary care providers, family physicians, psychiatry, therapy, even pharmacy services together, we can wrap things around the individual and enhance their outcomes. I'm almost out of time, so I'm trying to squish through my stuff. Summary: telehealth works, telemedicine works. It's transformative. When we can make things better if we use some digital strategies. I have some resources in here, so in the slideshow. So if you want to know more about any of these things, Center for Medicaid Services policy updates is really, really interesting. The AMA has some behavioral health tools, CMEs, other resources that are really good. And then the National Institute of Mental Health has some things on virtual support. And then I've got my list of references. And I'm going to stop there for any questions. I know we went really fast. I thank y'all for making time to come. Yes, sir.
So when treating like someone who has like comorbid disorders, like someone with a mood disorder or psychosis, as well as like substance abuse disorders, which is more important to like target first, like the substance abuse disorders or like the mood disorders, like which?
Okay, yeah, that's a great question. And so for our friends online, the question was, when people present with comorbid issues like either psychosis or serious mental illness and addiction, which one do you treat first? And so honest belief, personal belief, clinical experience, and the research all says the same thing. You treat both simultaneously. Simultaneous treatment gives people the best chance at improving, because if I work, for instance, only on someone's depression and it changes, they're going to see a change in their relationship to substances. And if I change someone's substance use, they're going to see a change in that depression. Vice versa, whichever types of disorder it is. Back in the old days, I say this, and I was there in the old days, we used to say, you got to get sober before you can get mental health treatment, or you got to get your mental health under control before you can get addiction treatment. And patients would go back and forth between these places. We called it ping pong therapy. And you know what? They never got better. They just kept going back and forth or eventually stop. So the best answer is treat both simultaneously.
Does AI have any role in substance abuse and addiction?
Okay, wonderful question. Very, very tricky. Does AI have any role in substance care, addiction care, psychiatry? I think it does, but I would be extremely cautious about it. And so right now, I think the role of AI and how it can come into being is for maybe people like us, if we're having a hard time drafting a question. If I'm having a hard time coming up with information that I want to give to someone, I would feel okay using AI. Now, at the same time, if a patient uses AI, current research has demonstrated it is not effective at delivering counseling or therapy or medical advice. That AI often hallucinates and produces information that's factually incorrect. It's hard to trace, and is even not often, occasionally harmful. So there are a number of cases across the nation right now where suicidal ideation or active suicides have been linked to use of AI tools. And so there's also, if you want to get real